Hey guys, today we're going to be learning how to backboard a patient. Once you've reached the step of your process where you're ready to backboard a patient, you have already finished your entire secondary trauma assessment in your scenario. By this time, you will already have a tertiary holding C-spine, as Matt is doing for me now. Once you're ready to backboard, there are a couple things you have to know. First of all, now that you know all of the injuries on your patient, you have to place your backboard on the most injured side so that when you roll your patient, it is onto the least injured side. For the sake of this video, we will say that the most injured side is the left side. Once you have identified that, you grab your backboard, walk it around your patient, and then lay it down with the red side facing their head, as such. You may put the board as close as possible to the patient so that it is easier to backboard once you roll them. After you have placed your backboard, there's one more thing you must do before you start rolling, and that is checking PMS, or pulse, motor, and sensory function of all extremities. For your upper extremities, your arms, you will check the radial pulses for presence. Next, you will place your hands inside of your patients and ask them if they can squeeze. Finally, to check sensory, you will hold one of their fingers and ask them if they can tell you which one it is. Keep in mind, for unconscious patients, motor and sensory is not necessary as they will not be able to respond to you. For the lower extremities, you will check the posterior tibial pulses for presence, and then ask your patient if they can push up on your hands and push down like a gas pedal. Finally, for sensory, you will hold one of their toes and ask them if they can tell you which one it is. Again, for unconscious patients, the last two steps are unnecessary. Now that you have checked PMS, you are ready to backboard your patient. Keep in mind, any movement of the patient must be led by the tertiary who is holding C-spine as to not compromise C-spine any further. Now that you're ready to roll, the one thing you want to do before you move your patient is put them into what is known as the Statue of Liberty position, which consists of putting the arm opposite of the backboard, pointing up, and the arm the same side as the backboard across their chest. This will make it easier to roll the patient and less difficult to get them onto the backboard. Now that the patient is in position, the backboard is in position, and tertiary is in place, the secondary and primary will interlock their hands to roll the patient. The primary will place one hand on the patient's shoulder and a second hand around their thigh, and the secondary will cross their hands with the primaries. Once in position, the tertiary will count down from 3 and signal the primary and secondary to roll the patient onto their side.
3, 2, 1, go.
Once the patient has been rolled to a 90-degree angle as shown, you must check for a few things on the back, including step-offs, exit wounds, or bleeding, palpating the spine while you're doing so. After you have done this and treated the necessary wounds, you may move on to rolling the patient onto the backboard. At this point, the primary will extend the hand that is not on the shoulder to grab the backboard and bring it right on top of the patient. Here, the primary will grab the opposite side of the backboard and bring it up at approximately a 45-degree angle to make rolling as easy as possible. Once in position, the patient may be rolled onto the backboard, again, on tertiary's count.
3, 2, 1, go.
Keep in mind, rolling patients onto backboards is never perfect, so once you've got them on the board, they have to be adjusted accordingly so that they are centered and ready to be strapped. For this patient, we'll put his hands back across his chest to make movement easier and move him first down and then up. Again, every single one of these movements must be led by tertiary. The primary, to move down, will put his hands on the patient's shoulders while the secondary grabs at the patient's hips. And then, after telling everyone that they are moving down, the primary will defer to tertiary for a countdown.
3, 2, 1, go.
Finally, the patient will be moved straight back up so that his head is right in the center of the red pad, and so that strapping can begin. To move up, the secondary will keep their hands at the patient's hips while the primary goes underneath the armpits to make movement easier.
3, 2, 1, go.
Now that the patient is approximately centered, strapping can begin. Throughout this entire process, tertiary will continue to hold C-spine, while primary and secondary strap. The primary will hand the secondary a strap and keep one for themselves. When strapping, you want to cut the body into 3 major portions: the shoulders, the hips, and the knees. These 3 will indicate where your straps are going to go during the process. The first strap will always be female end up on the highest hole of the backboard directly above the patient's shoulders. Once the strap has been pulled through, it will be crossed with the secondaries, with the right side going over the left, so that in the case of a cardiac arrest, the straps may be removed very quickly to apply AED pads. The next spot where the straps will go will be at the next cut, the hips. The primary will find the hole that is directly above the hips, in this case being this one, and signal the secondary to pull the strap up and through that hole. Once that strap is through, the primary and secondary will exchange straps and floss them underneath of the patient's knees to create a parachute type of hold on the patient. Next, we use what is called the 3-hole method to finish the upper portion of strapping. As you can see, there is one hole where the strap has already gone through. We will go down through the hole, 2 down from it, and then up through the one next to it, as shown. Finally, to complete the torso part of the strapping, we will clip the straps in to the top and then tighten. Usually, before tightening, we will ask the patient to breathe in so that their chest is full of air before tightening down. However, if the patient is unconscious, you simply bag them to inflate their lungs. The last strap will go at the 3rd cut of the body previously mentioned, the knees. The secondary and primary will hold the same strap and find the hole directly above the knees, in this case being this one. Then they will both go down with their sides and then come up and meet in the middle to click their strap in. Following that, they will take the strap and put the buckle down on the patient's legs. The primary will hold the strap while the secondary goes and holds the feet together so that they may be in place. Finally, the primary will make a figure 8 with the strap and cover up the patient's feet, having the secondary hold it in place while the primary tightens it until it is fit. Now the strapping is finished. The last part of backboarding will be head blocks. For head blocks to be applied, the secondary and primary must each have 1 head block and 1 head block strap. Throughout this entire process, the tertiary will remain holding C-spine, and every movement will again be on their count. The head blocks must be placed with the flat side facing the head of the patient and 1 at a time on tertiary's count. I will go first.
3, 2, 1, go. 3, 2, 1, go.
Once the head blocks are applied, the tertiary moves his hands to the outside of the head blocks to maintain C-spine. Next, the head block straps come into play. The secondary will put one down on the bottom, and the primary will put one on top on the forehead. At this point in time, your tertiary will be ready to let go of C-spine once the straps are in place. The last thing you have to do to conclude backboarding and effectively your scenario is recheck pulse, motor, and sensory function of the extremities in the same fashion that was done prior to backboarding. After that, sample and vitals may be reassessed, and then the scenario is concluded.